Welcome back to Endoscopy Essentials. We are continuing with our basic ERCP series. Welcome, Nageshwar Reddy. In the previous episodes, we talked about cannulation and difficult cannulation, including pre-cut techniques. We almost forgot one simple thing, the normal sphincterotomy. When you are in the duct, and then, Nagi, what do we do? How do we do it?
Yeah, so I think sphincterotomy was the first therapeutic endoscopic procedure after polypectomy which was done. And sphincterotomy, of course, there's a lot of art and science behind sphincterotomy. Before we actually go into sphincterotomy, it's important to decide what instruments that you're going to use. There's several sphincterotomes now in the market. I wouldn't recommend one or the other, but just one should know what each of them do. For example, the clever cut sphincterotome has got a wire which is covered in half with plastic, so that you can only cut with this part, the chance of perforation is less. The dome-shaped sphincterotome has a dome shape, and there is some very, very small evidence that maybe you decrease the chance of pancreatitis using this. And of course, you have the autotomes which can actually be moved to left or right, so that when you're actually doing a sphincterotomy, if your sphincterotomy is going too much to the left, to the right, then you can correct it to 11, 12 o'clock position. So these are several sphincterotomes. Again, no specific recommendation. Whatever you're comfortable with and what you're using in your unit, one should use. And of course, your assistant should be also used to know how to bow it and so on.
The insulation sounds very logical, but there's probably no evidence because it's difficult. Huh?
It's very difficult to produce. I think you will require 10,000 cases on both sides if you're on an RCT, so that's never going to come. But I think it's logical, because I've seen people who initially, when they're doing the cut, produce a zipper cut. Fortunately, we have now endocut or clever cautery devices where you don't produce this, but I think there was a danger at one stage.
Okay, so there's no specific recommendation. You should get acquainted with one sphincterotome and not use all of them all the time, and maybe have the others in the drawer as a rescue.
Yeah.
Okay, good.
So now coming to the actual technique of sphincterotomy, this is a video that illustrates this. You see, we already done a cannulation, and on the wire you are passing the sphincterotome. The important things are, first you can see we are doing an endocut in a graded fashion. We could discuss about the current later, and you can see we are constantly going at 11, 12 o'clock position. And in a very, very measured way, I'm doing small cuts till we go to an area where we believe it's safe. Now, how do you know how far to cut is a question that's often asked. We go to the end of the papillary fold that is there, as you can see here, and you can see that only 1/3 of the sphincterotome is inside, so 2/3 is outside. So you see, I come out again, assess, and then I can see the bile duct here starting to come in, and the folds are very nicely seen. So again, getting back to the technique, just to show you again so that it's very clear, you see only 1/3 of the sphincterotome is in. I'm cutting at 11, 12 o'clock position in a pulsed manner, pulsed cutting with the endocut. There are several cauteries available with different things. And you can see that as I'm cutting, I'm pulling my scope up a little, the shaft of the scope up a little, and then carefully watching the cut as I go up. And then cut to what I feel is the maximum point. The extent of the cut would also depend upon the purpose of the cut, whether we are doing with the large stones, small stones, and so on. You can cut the top part of the fold here, doesn't matter a little. Sometimes that happens, but it's okay to do that. And then I go to the end point where I believe is enough. And then when I do that, I actually pass my sphincterotome just to see whether it's adequate cut if the stone has to be removed. But you can see very clearly here that it is opened up. And I think this stepwise, 11, 12 o'clock, very...
and 1/3 of the ganglia?
1/3 of the sphincterotome.
Yeah. Okay. So you almost go to the end of the bulge. Do you always do that?
So there are two ways. If you want to do a standard sphincterotomy, not balloon dilatation, then I go to the end of the... suppose it's a 1 centimeter or less than 1 centimeter stones, I do a plain sphincterotomy and try and remove this. If it's going to be putting in stents, I would do a much shorter sphincterotomy, not needed to go in so much inside.
Does it depend on the diameter of the common bile duct, how far you cut?
So to a large extent, it depends on the diameter of the bile duct, especially when you're adding a balloon to that. But I think what is important is that it depends on what you're going to do subsequently. If you're going to remove 8 millimeter stone, even if the bile duct is very dilated, it doesn't matter. You're still doing a shorter cut. So I think the cut should be positioned according to the need, what you want to do subsequently, and of course the diameter of the bile duct.
What does the bulge mean? Does the bulge mean the bile duct is bigger, or have you seen bulges with very small bile duct?
No, bulge just indicates the intraduodenal part of the bile duct. So suppose you have only stone disease, the intraduodenal part of the bile duct, the bulge is big, then it's a large bile duct. But you can have a bulge in the bile duct when there's small amount of tumors in the lower end of the bile duct or fibrosis and so on, you can still get a bulge. So you'll have to decide what is the reason for this. Yeah.
But it's unlikely that if you have a very small bile duct, small stone, that you have a big bulge in the
Very
duodenum.
unlikely.
Yeah. So don't cut in
Yeah,
these instances. And you know the diameter of the common bile duct by at least ultrasound.
Yeah, but other thing, of
Before,
course, is when
or
you're getting
if-
contrast and you compare the size of the scope, which is usually 12 millimeters, then you know that's the size.
Okay, so that's a normal one. If you are in an awkward position, what do you do?
So again, I'll just show you another example, a little different because the fold is coming in here. Should you cut the fold or not? Yes, you can. The standard teaching is stop at the fold. No, you don't have to. You can cut beyond the fold right up to the point there. See that? I've gone beyond.
Again, depending on the size
Depending
of the bile
on the
duct.
need. And then
And
I
the
know
need.
that you can, actually the other important thing here, you can see after you cut, you're noticing a layer of bile duct here. This is a very important point to stop. If you cut beyond that, your chance of perforation is high. So you get two layers. This is the duodenal layer, this is the bile duct layer. So you can, in an abdominal position, of course, one will have to, sometimes your scope is looping, you have to do a long, and all depends also how much you have to go inside. This you can see the papilla is slightly in an intradivertical position. So in this case, often you're cutting the fold here, doesn't matter. You can cut a little of this. And then you have to do it from a long position, much longer position than normal. So your control is not so good. So in this case, you should not get very close to the papilla. You're doing it away from the papilla, but still because you have this long sphincterotome, you can actually position it and keep looking. The important thing at this stage is if you have a papilla which is very deep inside, you have to loop the sphincterotome much more. And now you can see that I'm looping the sphincterotome here much more to cut actually without touching the other side. So these are the small tricks that we have to sometimes do.
And as you said again, and I want to stress this, the size of the sphincterotomy depends on the purpose.
Exactly.
Yeah.
So there's no point in doing a large sphincterotomy for a small stone because there's also some evidence that you can later on get bacterial inflow into the bile duct and changes can occur and so on.
So it's not big endoscopist, big sphincterotomy, it's not true.
Yeah, that's I think like the surgeons, big surgeon, big incision is gone.
Yeah, okay. But there's one way out if you don't know whether you can continue cutting, that's the combination with a balloon.
Yeah. So I think we're now starting to use the balloon more for two reasons. One is if you have large CBD stones, the balloon is the best way to go about it. Secondly, if your anatomy is not very good, if you are, for example, if the papilla in a situation where you can't get a good cut, then I tend to use the balloon. So these are the two indications. And for example, in a papilla like this, you can see actually I'm not using a sphincterotome. There's only very few occasions like this where I have to use a cannula to get inside. And once you get inside, of course, you exchange for the sphincterotome. These are rare occasions that you can see. And most often the balloon we use very common now, it's called the large balloon dilatation. It's important that you always do a sphincterotomy. And as you can see here, we are cutting only half of the, so we are cutting about 7 or 8 millimeters maximum. There's a debate on how much to cut, but I will come back to that a little later. But you can see, put the balloon, we use a balloon. The dilatation again is tapered to what is the purpose and what is the bile duct size. In this case, there are large CBD stones of about 15 millimeters, so I'm dilating it up to 15 millimeters. And once I've dilated, release the balloon, you can see we create a nice opening. Again, we can discuss specifics about how long to dilate and so on. And you can see that we can pass standard extraction and a large stone has come out.
Are there any rules? So if you say I want to have a sphincterotomy of, I don't know, a hole of about 12 millimeters, you cut 6 and do the rest with a balloon, or is it more individual?
Yeah. Again, there are two schools of thought. There are some people who would cut nearly to the end and then do a balloon dilatation. But I believe that if you're doing a large balloon dilatation, the purpose of large balloon dilatation is to direct your balloon up towards the bile duct, not the pancreatic duct. So I would normally recommend half to 2/3, not more than that, for balloon dilatation. We tend to use a balloon of 5 millimeters. We are now getting specific papillary dilatation balloons. Earlier we used to use the regular balloon, which was used for other purposes, the CRE balloon, but now we are getting specific balloons. Now once you go inside, the principle is to, of course, as I said, dilate according to the common bile duct size, that we dilate, and as we are dilating, we watch the waist. And once the waist goes off, then of course you stop dilatation. A lot of people think that that is enough, don't dilate further, but I think it's important to keep it on at least for 60 seconds for two reasons. One is I found that often when you keep it on, the opening appears much bigger, and second, any ooze coming at that point of time stops. So bleeds can occur. So that's the reason why I always suggest when you're deflating the balloon, don't do it suddenly, do it in small steps, so that once you deflate it completely. It's important to position your balloon in exactly mid portion. And when you position in the mid portion, sometimes the balloon slips up and down. So the trick in that case is to close the papilla, and then actually the catheter forms a U shape, and then it keeps in position so that it doesn't slip out and down. So positioning of this balloon is very important.
Nagi, sphincterotomy has a certain perforation risk.
Yes.
If you add the balloon, there is no additional risk almost. Is that correct?
I think if you look at all the studies that have been done, if your balloon dilatation is up to 15 millimeters, the chance of perforation is almost zero. But if it goes above that, most of the perforations have been reported at 18 or 20 millimeters. So even if the bile duct is dilated to 20, I would still like to do only a 15 millimeter dilatation. Because nowadays, if you have a stone which is 3 centimeters, you can still do laser or EHL and then break the stone and take it out.
So 15 is a kind of a
15, I would
cutoff.
say, is a cutoff almost, yeah.
Even if the bile duct is huge?
Even if the bile duct is huge, I would do only 15, because I think the perforations that have been reported from Korea in the series was only not related to the bile duct size, but related to the balloon. Any balloon which went 18 and above, chance of perforation came in.
Good.
So there are certain occasions where we have to do a balloon sphincteroplasty without sphincterotomy, very rarely, especially in patients who have coagulative disorders, for example, cirrhosis of the liver, or in a B2 situation where you can't cut. In these situations, I use again the standard balloon, but I would now like to actually do a longer duration of balloon sphincteroplasty. So no cut in this case. I'm actually putting the balloon on for at least 3 minutes, not 1 minute. This is paradoxical, but if you do a longer dilatation, less chance of pancreatitis because you're opening up. And you can see here in this case, it's a B2, so we've gone in, we are opening it up, and as I'm doing that, the balloon tends to slip inside, so I'm pulling it out all the time to keep it in position. And then you can see we can remove fairly large stones after this technique. So this is, I think, an exception. Usually one would want to do a sphincterotomy followed by sphincteroplasty. Okay, and of course, coming to a B2 situation, I think it's important that, of course, you go into the afferent loop. Identifying the afferent loop itself is a technique. Once you go into the afferent loop, you can see the papilla is actually coming at 6 o'clock position, a totally different position, and the bile duct is going down at 6 o'clock position also, not 12 as you can see. And once you go inside, you identify the papilla. The technique of cannulation and sphincterotomy is different. You can see the papilla coming up there. It's about down, so you're positioning it down in this case so that your cannulation, and we use a straight cannula in these cases, not a sphincterotome, because your bile duct, remember, is going down this way at 6 o'clock. And then I put a guide wire inside so that once the guide wire is in place, here I got two options. One is to put a stent, as I'm doing in this case, and do a needle knife sphincterotomy to complete the sphincterotomy, or I can put a balloon like we showed you in the previous video and then do a balloon sphincteroplasty to open it up. The needle knife has to go in a different direction. You can see here I'm directing it down at around 6 o'clock position, and not 12 o'clock. This is very important, remember, when there's altered surgical anatomy, and this can be seen nowadays in patients who had bariatric surgery and so on when you do this. So the stent is in place and I'm opening it up again layer by layer completely, And once it's opened up completely, then I can put in a balloon or open it up completely, or even extract stones by this technique. So this is a different technique that we use sometimes in a patient who has an altered anatomy. I remove the stent now and then put in a basket so that I can remove the stones. Yeah.
So no place for these B2 sphincterotomes, or
No.
using a normal one and trying to rotate and dance around?
No, I think B2 sphincterotomes are now withdrawn from the market, and the normal autotome, which we sometimes use to turn, is not very effective in this situation. So I would just put in a 7-French stent and do a nice needle knife directed on that, and then remove the
Or a combination of both, needle knife and balloon.
balloon. Yeah, then you can do a needle knife, and you can, if you want large stones, then I would also combine it with the balloon like we showed you earlier.
Okay. Thank you very much, Nagi. That was a superb tour d'horizon through EST. I think we are coming back with more cases, difficult cases, tips and tricks. And thanks very much.
Thank you, Thomas. Thank you for giving me the opportunity to participate. I think this is an important way of learning, a new way of learning now.
Thank you.
Thank you.